Welcome to AETCM, the Emergency Medicine channel. So, 64-year-old female patient came to our emergency department with a complaint of cough with difficulty to spit out the sputum and history of intermittent difficulty in neck holding since 1 week. On arrival, on initial tension assessment, patient was conscious and oriented. Coming to the airway was appears patent. There is no pooling of secretions. In breathing part, air entry bilaterally equal, normal vascular breathing sound, respiratory rate is 18 breaths per minute, and saturation is 96% room air. Coming to circulation, BP was 110/60 millimeter mercury, heart rate is 77, and regular in rhythm. Coming to disability, GCS was E4, V5, M6, pupils 2 millimeter bilaterally equally reactive, and exposure was vision was febrile. Coming to the adjoint to the primary survey, we have taken a ABG pH showing 7.35, PCO2 is 53, PO2 is 68, and bicarbonate is 29.
PCO2?
53, and PaO2 is 68, and bicarbonate 29. In ABG wise, patient in type 2 respiratory failure.
With compensation, without compensation?
It is, if you look, taking as a chronic component, it is a compensated. Then we taken a CBC point of care in view of cough since 1 week. CBC was point of care is negative. Then we taken a chest X-ray to rule out any LRTA in infection. Chest X-ray looks normal.
When chest X-ray is normal, what are the reasons for type 2 respiratory failure with compensation?
One is obstructive airway disease.
Obstructive sleep apnea syndromes. Okay.
Airway disease with non-infective exacerbation.
Airway disease with non-infective exacerbation like asthma. But asthma normally type 2 respiratory failure you don't
severe
see.
Asthma or COPD with non-infective exacerbation.
Okay.
Then some if patient is bronchiectasis patient, mucus plug causing spasm.
We'll see some X-ray findings. I am telling without X-ray finding, without auscultatory finding, we are getting type 2 respiratory failure with compensation. What are the possible reasons you suspect? One you told obstructive sleep apnea syndrome.
Other neurological disorder.
What are the,
one is Myasthenia gravis.
One is Myasthenia gravis.
Other variant is Lambert-Eaton syndrome.
Okay, well, that is Myasthenic syndromes. Okay, then
motor neuron disorder.
Motor neuron disorders. Then
other is Guillain-Barré
syndrome. Okay, then
snake bite.
Snake bite is an acute problem. Even then, it can. Then what else?
Myositis.
Myositis, rarely it can produce diaphragmatic weakness. There are conditions which involve phrenic nerve, which selectively targets diaphragm. Diaphragmatic weakness, bilateral diaphragmatic weakness can produce this type of
C3 to C5 cervical
fractures, cervical compressive. All these things can produce. Okay. Don't think that only respiratory problem will produce all these things. There are supra-respiratory reasons can produce same problem. Same problem in ABG. Okay.
So patient presented with cough, with history of cough with difficulty to spit out the sputum and history of difficulty to neck holding with an ABG showing type 2 respiratory failure. We suspected and there is no infective pathology. We suspected a neurological problem causing this much of things. So we evaluated the patient. We done a chest X-ray to rule out infection and rule out thymoma-like features, any enlargement of mediastinum. Then we, as a bedside test, we can, the patient is not ptosis, but as a bedside test, we can do ice pack test for this patient.
For ptosis improves with ice pack.
Because of hypothermia, there is transient improvement in the ptosis is there.
Okay.
Other bedside test we can do, one is hydrophonium. Ancient time we use hydrophonium test, penicillin test. We can now, hydrophonium is not available, we can use with neostigmine. We can give neostigmine, which is 0.5 mg. Prepare the patient with atropine 1 mg.
Okay.
Because neostigmine causes bradycardia, we can reverse it by giving atropine. Okay. So if the patient symptom is improving with giving neostigmine, we can suspect patient Myasthenia gravis.
Okay.
Other confirmatory tests are available. Confirmatory tests are electromyography and electrophysiology study like repetitive nerve stimulation test and nerve conduction studies and other serological tests.
What will happen in repetitive nerve stimulation study?
In repetitive nerve stimulation test, there is decremental response. Every time we give stimulation, patient muscle potential will be decreases.
Okay.
Other thing is serological test. Serological test, we can test the Myasthenia gravis autoantibodies. It is an autoimmune condition. Autoantibodies are against the acetylcholine receptors.
What are the antibodies commonly used?
One is acetylcholine receptor antibodies.
That is one. Second thing is?
Second,
anti-musk
antibodies.
Okay. These are two things, two common things. If it is negative?
Both things are negative, then it is seronegative Myasthenia gravis we can take.
Okay.
By doing electrophysiological study, if it is positive, you can do it as seronegative Myasthenia gravis.
Okay.
In this patient, we done a bedside neostomy test. It becomes positive. So we take
positive means patient improves
the symptoms.
Is it a transient effect or
transient effect?
Okay. We give very small dose. So it gives only transient effect.
Then we done a electrophysiological study for this patient. RNS we done. It is decremental response. So we started the patient neostigmine.
This is a elderly female patient. You have a myasthenic symptom in this patient. What else you want rule out?
Myasthenia basic pathogenesis is autoantibody production. So we will rule out other autoimmune conditions.
Other autoimmune condition or some
paraneoplastic syndrome.
So you basically take an X-ray, see thymoma is there, other lung malignancies are there, ovary has to be examined, gynecological examination to rule out malignancies there. If it is a male, testis we have to examine, ultrasound to be done. All these things, there are a lot of investigation to be done in this patient to understand whether it's a primary or secondary myasthenia. Primary is myasthenia gravis, secondary is Eaton-Lambert syndrome.
Eaton-Lambert syndrome is like production of autoantibody towards the voltage-gated calcium channels. So because of that, there is because of calcium influx, ACG is releasing.
So release is abnormal there. Other one is production is abnormal.
Okay. So this patient bedside test is positive and electrophysiological RNS test is also positive. So we plan to start neostigmine is 15 mg TID and pyridostigmine dose is 60 mg TID with glycopyrrolate 0.5 mg.
Okay. Why glycopyrrolate?
Glycopyrrolate because neostigmine and pyridostigmine basically their mechanism of action is they will inhibit the acetylcholine esterase enzyme. So there is increased amount of ACH. So there is muscarinic effects will be there. Increased salivation, increased secretions to prevent that
like OP poisoning. And patient can have bradycardia also. To counter that, you are giving
glycopyrrolate.
Okay.
So after starting these drugs, patient will symptomatically become better.
Okay. What is the role of steroids here?
In acute, we can give steroids, but chronic stage, steroid already causes proximal muscle weakness. In myasthenia also, most
so better to avoid because of it, that itself will produce myopathy. Okay, what other treatment options are available for this acute condition?
Acute condition with the antibody is positive, we can start intravenous immunoglobulins, IVIG, or plasmapheresis we can do. In acute emergency condition, if the patient is severe respiratory distress, severe respiratory failure, not able to achieve the vital capacity, patient is not able to control the oral secretions, then we can do the patient can put in a mechanical ventilator.
Okay, how do you intubate this patient?
In this patient, if you're using deep paralytic agents, we will decrease the dose.
Okay, because the requirement is very less, and sometimes you'll have to reverse it with
Sugammadex.
Okay. That has to, we should know all these things. Okay, blindly you cannot give a drug and after extubating, patient will deteriorate. Okay, what are the drugs to be avoided here? This patient has come with acute breathlessness, cough. So what antibiotic you will avoid?
Antibiotic groups are macrolides, azithromycin, clarithromycin, aminoglycosides like amikacin, gentamicin, dobramycin, fluoroquinolones, levofloxacin,
So a lot of
oxyfloxacin.
drugs we use in acute symptomatic respiratory disease cannot be given here.
Other than that, beta blockers like metoprolol, propanol, atenolol, then antiepileptic drugs, anti-malaria drugs.
There are a lot of contraindicated drugs are there in acute myasthenic crisis. Okay. How do you differentiate myasthenic crisis from cholinergic crisis? This patient can come back after some days to ER again with breathing difficulty, muscle weakness. So how do you know that it is myasthenic crisis or cholinergic crisis?
In myasthenia crisis, after giving neostigma
That is giving, after
patient,
giving. Before that, how do you know?
after arriving that, if you
one is people, same like OP poisoning. Like people will be
pinpoint people in
other one it will be normal or
dilated.
dilated, and sweating will be more in
cholinergic crisis.
So like secretions, other secretions also will be high. Okay, so you can get you may get a clue from pupil and other secretions, but like you told, the ideal thing is you give this one
Symptoms is
neostigmin.
improving.
If it improving, then it is myasthenic crisis. If you give atropine, if it is improving, it is cholinergic crisis.
Otherwise, if giving neostigmin, crisis is worsening. Cholinergic crisis.
Okay.
Other bedside test is one is Cogan's twitch test. That is ask the patient to look downwards around 10 to 15 seconds. Already patient is ptosis. So for that patient, ask the patient to look for 10 to 15 seconds downwards. So in resting state, eyelids becomes more active.
Okay.
So after 10 to 15 seconds, then ask the patient to look straight.
Okay.
At that time, patient will develop ptosis.
Okay. So that this patient had only weakness in swallowing, neck, and
difficulty to speak out.
What type of myasthenia it is?
That is bulbar, like grade 2 myasthenia, according to.
So there are different types of myasthenia. One eyes alone will be
ocular myasthenia gravis.
One is
generalized
bulbar, and the other one is generalized. Here, this patient presented with bulbar symptoms. Not eyes are not involved. Ocular is not involved. Other muscles also not involved. Only bulbar is problem.
That we can classify as ocular myasthenia gravis and generalized myasthenia gravis, and other classifications also one classification. That is according to class 1, it is only affecting the ocular muscles, and class 2A is mild generalized myasthenia gravis, class 2B is moderate generalized myasthenia gravis, and class 3 is acute fulminant myasthenia gravis, and class 4 is severe form. Patient came with respiratory failure.
Okay. What else you want to tell?
Other than patient with ptosis, differential diagnosis is like brainstem stroke, bilateral oculomotor nerve involvement, snake bite, other variant of myasthenia gravis. This also will suspect if a patient came with ptosis with type 2 respiratory failure in or mind.
How do you manage snake bite with my crisis, like ptosis, breathing difficulty?
Same as we can start with pidostigmine and we can give atropine along with that.
Pidostigmine. Cobra bite, how do you manage? Cobra.
Pidostigmine.
Neostigmine. Neostigmine with atropine. Whereas in crate bite, calcium gluconate. The other one will not work. Calcium gluconate. Okay. What other conditions will present with bulbar weakness?
Cranial nerve palsy.
Bulbar weakness is cranial nerve palsy, 9th and neck weakness. What is Miller-Fisher variant of GBS? Is it Miller-Fisher? Descending type of myasthenia, and where initially bulbar weakness will be there, cranial nerve will be involved, and later patient descends the weakness. The weakness will descend. Where else you get a descending type of weakness? What are the differential diagnosis for myasthenia? So all muscle weakness are not myasthenic problem. So one is this Miller-Fisher variant, but it takes time. Snake bite is another problem. Then tick bite. Tick bite can have similar finding of Miller-Fisher variant. Botulism. Botulism also will have similar finding. So there are a lot of other conditions, including hypokalemia, hypomagnesemia. They all will present like this. Hypokalemic periodic paralysis. They present like this, but predominantly that neck muscles will not be involved. Large muscles will be involved. Polymyositis and this myasthenia, how do you differentiate? So we had a polymyositis case last week. How do you differentiate?
One is polymyositis, one is demyelination is in the
polymyositis. There is no demyelination.
Proximal muscle.
CK will be
more than 5,000.
Patient will have painful muscle weakness with elevation of CK. Here there is no pain. There is no elevation of CK. Only muscle weakness is there. Whereas in polymyositis, muscle weakness, painful myopathy, and CK will be very high.
More than 5,000.
Maybe 5,000, 10,000 like that. Okay.